welcome every one of you. I so appreciate that you've taken this time to be with me this morning to engage in this really important conversation about suicide in older adults. Next slide. And just quickly to go over my objectives. I'm not going to go over all of them, but really want to include your knowledge about what are some unique risk factors that are pertain to older adults. Why is it important to know the connection between depression and suicide for older adults? Then really look at how do you assess for suicide risk, and then learn some prevention interventions and strategies. So that's kind of the gist of my presentation today. And by the way, you will be getting this PowerPoint presentation and also in addition, some more supporting documents, which I have sent out to Kelly and Angela. Next slide. So let's just begin with some facts to set the stage. And this is overall suicide rates. 10th leading cause of death in the United States. 10th, more than traffic deaths and twice as many as homicides. It is the third, actually, I need to change that. In Oregon, so in the country, it's the third leading cause of death for those 15 to 24, but in Oregon, it is the leading cause of death for those ages 15 to 24. So for our youth, suicide is the leading cause of death in Oregon. Look at that staggering number. In 2018, a little over 48,000 Americans died by suicide. Let that sink in for a minute. 48,000 Americans died by suicide. And then if you look in addition, almost 1.5 million people attempted suicide. When you combine that, it is staggering that there is so much pain and suffering. In 2014, 20 veterans died each day. And the sad thing was 6 of the 20, that's almost, a little over a quarter of them were using VA services of some kind. And they veterans' death account for 18% of all suicides. And they were all older, the veterans who died by suicide were actually all older veterans. So they were 50 plus. This is just highlighting some gender differences. Ideation and attempts are very much higher in women, and mortality is higher in men.
Nirmala, excuse
Yes?
me. Can I stop you? We have a participant that needs to be able to lip read, and I'm wondering, we seem to have lost our visual on you, unless I'm looking at your lovely tablecloth. Would you be willing to move your camera so that this participant can actually see?
I can't see myself. I don't know, so can you see me now?
No. I think I'm looking at the tablecloth. I'm not sure what we're looking at, but somehow we.
How about this? Is it better?
That's much better. Thank you.
Okay.
Thank you.
Okay.
We have visual. Thanks.
Okay. So like I said, the gender differences, ideation and attempts are higher in women, and mortality is higher in men. And again, why am I giving you 2018 data? Because that is the most recent data from CDC. Firearms accounted for a little more than half of all suicide deaths in the United States. By the way, worldwide, remember I said in the United States it's 48,000, a little over 48,000. Worldwide, the total number of people who died were 800,000, so close to 1 million died by suicide. So that is worldwide. However, the rate of suicide that means per 100,000, is very high in the United States. Even though our numbers are 48,000, our rate is very high. But I just wanted to give you a global perspective that it's also a huge problem in other countries across the world. And if you did not know this, that depression is the #1 disability worldwide. Next slide. And so, we talked about some differences. Here is suicide rate by age. And if you can look at the top bar is older adults, and you can see, 65 plus, it's pretty high. Also the next two bars. So basically from age 54 to 65 plus in adults, it's pretty significant. And you can also see the gender differences. The light blue is female and the dark blue is men. And we'll talk a little bit about this later. Next slide. I also want to show you race and gender differences. If you can see huge differences. The blue is white males. The purple is black males. The kind of the ochre color is white female, and right at the bottom is black females. And what does this tell you? That there are huge racial, ethnicity, and gender differences in suicide deaths, with white males leading the numbers. That white males have very high rates of across the age span. So it begs the question, why do we have these racial and gender differences? Why are black males, even though they have a higher burden of disease and social determinants, and also Hispanic male, why are their suicide rates lower? And I'm just going to pique your interest. I'd love for you to explore that question. There are lots of theories, but I just wanted to give you the gender difference. Next slide. Look at suicide again, a rural-urban difference. And if you can see, again, in rural areas, it's higher than in urban areas. And if you see the red line on top is rural, and the ochre line is male, and that is the urban and rural difference. And there are lots of reasons for it. One of them is access to behavioral health services, crisis services, gun ownership, older population. So lots of reasons. But I wanted to show you that yes, there's also a difference. A smaller difference for women, but a much larger difference for men in terms of urban-rural suicide rates. Next slide. So with all of that data, why am I giving you this data? So that it will inform your work. So you can take this data back and share it with your organization, with your leaders, with your supervisors, and ask the questions. What are we doing? Are we really developing programs based on data? Because the data is very clear that older adults have very high rates of suicide. So here are the highlights. We tend to give less attention to late life suicide than to younger age groups. And granted, yes, it is the leading cause of death for youth in Oregon, but it's also significantly high for older adults. Internalized ageist stereotypes are associated with this reduced will to live. When you're constantly bombarded by media images and all around you, where older adults are not respected, not valued, it's very easy to internalize that. One promising prevention strategy, they say, is geriatric medicine. Duh, we all know that, but how many rural areas, or even urban areas for that matter, have trained geriatricians or have trained geriatric clinics? That is an aspirational goal, but we don't have it. Addressing ageism as a universal prevention strategy is essential. And so again, all of you on this call, addressing ageism is something we all can do. We are all addressing racism. We are all encouraging an anti-racist practice, an anti-sexist practice. So we need to even add anti-ageist practice to that. Next slide. And here is some information again about deaths, suicide deaths. Again, you can see firearms is overwhelmingly the choice, the method, followed by suffocation, poisoning. Someone at one of my trainings last week asked what I meant by poisoning. It's most often it's medications in the United States. In other parts of the world, it's actually poison, and then other methods. Next slide. And here is some more Oregon specific data. Next slide, which shows, gives you some of what I just said. Remember I said it's the leading cause of death for ages 10 to 24 in Oregon. And nationally the rate is 14.21 per 100,000. In Oregon, it is 19.2 per 100,000. So it is higher than the national average, and we are, I think, we rank 16th in the country. On average, one person died by suicide every 10 hours in the state. And just an interesting fact that suicide rates are much higher west of the Rockies. So in all of the states west of the Rockies than east of the Rockies. Again, that is something to pique your interest and for you to really take a deep dive into, hey, what are the possible reasons for that? And where the all another interest for us on the that means we have a higher suicide rate overall for all age groups than both Washington State and our neighbor to the south, California. Next slide. So here again, I don't want to go too much into data, but here again are you can. I was giving a talk to Marion and Polk County, but we can skip that slide. You can just move on to the next one. And by the way, you can get your own county's data, available to you on a website, which I'll give you the link to at the end. Mechanism, again, I don't need to belabor the point, but firearms is huge for older adults and compared to younger adults. Can you see? It's pretty glaring, what the percentage is compared to older and younger adults, the use of firearms to end their lives. Okay, next slide. So, 47,000 people died from overdoses in Oregon. Remember, I said 48,000 died from suicide in 2018. In 2017, 47,000 died from overdoses of opioids. And what's important, why I'm bringing this up, concealed in this number is a significant number of people who decided to take their own lives. That means it was on their death certificate, it says overdose, but it was probably a suicide. So I just want to put that out there for you because we are in the midst of a suicide crisis. And if you've seen the latest reports that there has been an uptick during this COVID-19, the early 3-4 months of the pandemic, where we've seen an increase in overdose deaths from opioids. So I just wanted to highlight that. Next slide. So really, I want to convey just a brief message that we've often heard the following. Of course, they want to die. They're old. I may want to die when I get to that age. That is that ageist stereotype, so the ageist assumptions. And the message is that suicide is not a normative response at all. And so we need to bust that ageist in our practice in terms of how we engage with older adults, that it is not the norm at all. Next slide. And so what is the significance? Why am I saying this? Why are we all here about older adults? Older adults are the most rapidly growing segment of our population. Currently, 16% of Oregon's population is older adults. And by that, I mean 65 plus. If you add 60 plus, it's higher. And by 2030, when the last of the baby boomers turn 65, our population will be between 20 and 22%. Did you know where many of you come from in Central Oregon, especially Jefferson and Crook County, already look like what Oregon will be in 10 years? That means you already have a very high, prevalence of your population is already older adults. That means they're 65 plus. Two other big changes coming our way in 2034, which is 14 years from now. We will have more older adults than individuals under age 18. That means we'll have fewer births and a growing older adult population. So yes, that will be the first time where we'll flip the pyramid, where we will not have, we will have fewer individuals under age 18. And then the very big one is coming in 2040, when the racial ethnic mix of a United States population will flip, where in the aggregate, United States will be majority brown and black in 2040. So so these are huge demographic changes coming on the wave of this aging population. And so you need to be, how are we going to serve this population? Who's going to take care of them? When we are saying there are not going to be enough, younger people in our population, where we may have more minority and immigrant people serving, what do we need to put in place? So that is significant. Older adults have higher rates of suicide than other segments of the population. And lastly, very important, suicidal behavior is more lethal in late life. Next slide. And so why is this lethality in late life important? Why are we talking about it? Because older adults are more frail. So they're more likely to die or less able to recover from an attempt because of their frail. They're more isolated, especially if you're living in rural areas or you're living alone in an urban area and you have a very limited social network, which is true. Both of those are true. You're more isolated, so you will be less likely to be rescued. And lastly, older adult suicide, they are more planful and determined. That means their intent. So there's often very decreased expression of suicidal ideation. And so what happens, so that those are reasons why life suicide is so lethal. Next slide. And this is a good framework that I want to share with you, which is good for all of you busy clinicians, paraprofessionals, whether you're in nursing homes or you're a law enforcement person, what we call the 5Ds of suicide. And this comes out of the work of a geropsychiatrist from University of Rochester. His name is Dr. Conwell. So 5Ds are demography. That means if you're white, male, and you're unmarried or single, very high risk. You have depression. You have disease. That means you have some kind of chronic physical illness, which leads to, a disability. Disconnectedness, that you're socially isolated, you have very limited social support. And lastly, deadly means, that you have access to firearms. So those are the 5Ds for older adult suicide. And this is a good way for you to carry this framework in your head: demography, depression, disease and disability, disconnectedness, and deadly means. Next slide. And we've, I don't want to belabor the point about lethality, but it is so significant for this population. Older adults are twice as likely to use firearms as a means of suicide than younger people under the age of 65. And what does this suggest to all of us on this training today? That interventions must be aggressive. and that multiple prevention methods should be used just because of the lethality of suicide in this age group. Next slide. So what are the risk factors for older adults? Depression. That means the presence of depression. Prior suicide attempts, comorbid medical conditions, which can be significant, sometimes 3 to 5, whether it is COPD, painful arthritis, it could be some kind of other neurological problem like Parkinson's disease, it could be diabetes, so comorbid medical conditions. Often pain, many of these diagnoses carry pain with it, significant pain, especially if you have cancer. And role function decline, where you are unable to carry out your role, as an independent, autonomous adult. That's just one role. We have many others. That you are more dependent on care, or for your activities of daily living, and you are isolated. There is high degree of family discord, or you're experiencing losses, that you have some very specific personality traits, which are inflexibility and rigid coping styles. That means you aren't very flexible in thinking about solutions and looking at different perspectives. So you're very inflexible and very rigid. If I can't do this, then nothing is worth living for. So very rigid coping styles. And very importantly, you have access to lethal means. And so you can see how very different these risk factors are from younger adults. For what jumps out right away is always the presence of depression, comorbid medical conditions, which you will not see a lot in younger populations, pain and role function decline again, not in younger, then dependency, and then high levels of gun ownership. Next slide. But what really jumped out to me when I was preparing for this talk was high psychiatric illness in older adults who die by suicide. Psychiatric illness is present in 71% to 97% of suicides, a completed suicide by older adults. 97%, as you can say, almost every older adult who died by suicide. The most common is affective disorders, and from that list of affective disorder, major depression was most closely associated with suicide. So if there's one take-home message today for you, is that depression is almost always present in older adults who are experiencing suicidal ideation, or who die by suicide, or who are at risk for suicide. And the question is, what are you going to do with this piece of information? Next slide. Also very important, along with the presence of depression, is medical comorbidity in this population. So in younger adults, remember, this is a problem along the lifespan. With abuse and personality disorders complicate major mental illnesses and their risk for suicide. In older adults, the group that we are talking about today, comorbidity is not psychiatric comorbidity, but it is characterized by concurrent mental and physical illness, with cardiovascular and cerebrovascular disease playing a prominent role. So can you see how different it is? What the comorbid diagnoses in younger people are, and what is the comorbidity in older adults. So that is the other big difference that I want to share with you. And again, the question is, what are you going to do about it? For all of you primary care, or say in a long-term care, do you screen your individuals who have cardiovascular disease for depression? Because you should, because that's a risk factor. Next slide. So we've talked about medical comorbidities. Look at how it impacts older adults and their risk for suicide. As an individual's acute and chronic conditions increase, so does the cumulative risk of suicide. So the more diagnoses you have, the more disabling the illness, the risk for suicide increases. Beyond the number of physical illnesses, remember I said people over 65, and you can just peruse the Medicare claims data, the literature where they explore claims and they look at diagnoses. So, it's clearly 3 to 5 to 7 physical illnesses. So beyond just the number, what is more important is the perceived meaning of those illnesses, their impact on your functioning, whether they have pain associated with it. So impact on your functioning, whether you can walk, you can talk, you can use the toilet, you can drive. Pain, threats to autonomy and personal integrity play a pivotal role. Am I going to lose my sense of self? Do I need to be dependent on someone to change my underwear, take me to the bathroom? Those are all threats to your autonomy and personal integrity. Will I be who I have been all my whole life? That is as important as the number of illnesses you have. So for all of you who are therapists and case managers and behavioral health folks, I would behoove you to explore the meaning of physical illness with your older adults who are, who are coming to you. What does this illness really mean to you beyond just symptoms and taking your pills? How is it impacting your functioning? And more importantly, how is it impacting your sense of personal integrity? And I would highly recommend you read a book by Lust Bader. She's a social worker. It's called Counting on Kindness, where she explores this dilemma. Next one is association between severe pain and suicide was stronger among men than women, and how important it becomes to really aggressively treat pain and really have that portfolio of pain management interventions available for older adults. And lastly, very important, identify older adult patients at risk of suicide and open avenues for prevention aggressively. Next slide. So again, I'm just going over recapping. What are the risk factors? Functional impairment, pain, dependence, decreasing sight and hearing. That's a big risk factor. And that we've seen that there's a clear relationship between the number of medical or physical disorders or comorbidities you have, psychiatric symptoms, and your risk for suicide. Next slide. And I was very surprised when I did a literature review to see that these medical diagnoses are very high risk for suicide. Cancer, almost 55 to 60% of people with cancer, older adults with cancer, have a depression, and it's a risk factor. But look at the other ones: epilepsy, AIDS, spinal cord injury, Huntington's disease, which is a devastating neurological dementia kind of illness, and brain injury. All of these elevate a person's risk for suicide in themselves. And then when you couple it with age, it even elevates it further. So all of you who are working with someone with epilepsy or with cancer, are you actually screening for depression and suicide risk? Next slide. So again, there are some social factors which also play a role in the pathogenesis and in prevention of suicide in older adults. One is, there are two broad categories. One is stressful life events as a predisposing factor. And you will see later in all of our screening instruments, we look at that. What are the stressful life events happening concurrently in your life? And the second one is social connectedness as a buffer or as a protective factor that serves to reduce suicide risk. You should be asking that question every time you do a suicide risk assessment or every time you do an assessment of a person's well-being. What is their social network? How connected are they to others? Because it is a buffer. Next slide. So what are these stressful life events preceding suicide? Why are they important? Because people who die by suicide tend to be more, those stressful life events preceding suicide tend to be more severe and numerous among people who died by suicide than controls. That means people who did not die by suicide. And what were most salient to late life suicide associated with aging? Threats associated with ill health, functional impairment, loss, often through bereavement or ruptured family relationships, and other sources of support. Those were the most significant predisposing stressful life events. And how many of you routinely explore that with your clients who are older? I again want to emphasize ruptured family relationships. Why? Because one of the evidence-based practices for treating ruptured family relationships and depression is I'm blanking on it. It'll come to me. Interpersonal psychotherapy, which is an evidence-based treatment for older adults, which really looks at role changes and all of that. So it is highly recommended that if you're not using interpersonal to ITP, to use it for. It is very effective with older adults. So those are the salient features of stressful life events. Next slide. Something more about social connectedness. The CDC has identified as a key strategy for preventing suicide behavior of all ages, not just older adults, the promotion and strengthening of connectedness at personal, family, and community levels. So I'm going to ask Central Oregon, what are you doing to promote and strengthen connectedness at the community level? How are you promoting increased family connection, especially during COVID-19? That is a key prevention strategy. Older adults who completed suicide were less likely to have had a confidant, more likely to live alone than their peers who did not, less likely to participate in community activities or be active in any kind of an organization or have a hobby. So they were really lonely people. Having a greater number of friends and relatives in whom to confide was associated with reduced suicide risk for older adults. So there you already have an intervention that you will need to work on with your clients and with your community. How can you foster friendship? I have this idea. I've been working on a little work group with social isolation. My idea is to create virtual friendship pods with lonely seniors, by providing them with grandpads or whatever, but actually facilitating it to create these communities, which I'm calling virtual friendship circles or pods. That is one way. So my question and challenge to you is, each one of us can promote social connectedness. It doesn't require a lot of money. How are you going to do it? Are you doing it? More importantly, it's not just creating a new program, but actually looking at, is it actually meeting the goals of what we wanted to do? Next slide. So next slide, I want to really talk very briefly about this theory of suicide. It's called the interpersonal theory of suicide by Thomas Joyner. If you have not heard Thomas Joyner, if you ever can hear him, he's a wonderful, powerful speaker. He's one of the leading suicidologists in America. And he got into this field because his father died by suicide. And so this is his interpersonal theory of suicide, where he says these three elements have to be present in a person for them to have that kind of overwhelming desire to die by suicide. And of course, they have to have the means, etc. One is thwarted belongingness. I am alone. And we just spent the last few slides talking about disconnection. and social lack of social connection. So the sense of I'm alone, I don't belong, I don't have anywhere to call home in the psychological sense. The second is perceived burdensomeness. I'm a burden. I'm useless. Why am I here? And can you see how this fits in with older adults? And then the last component is I'm not afraid to die, because we are hardwired for self-preservation. So we have to overcome that fear to 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 preserve life. And when he says when these three elements are there or components are there, someone is ready to die by suicide, and that is the interpersonal theory of suicide. And if you look at the next slide, again, the same geropsychiatrist that I've been talking about from Rochester University, his last name is Yates, Yates, first name Conwell, Conwall. He took Joyner's theory, which is in the middle, in the colored purple, yellow, and orange circles, Venn diagram, and then he superimposed on it all of the challenges that older adults face, and he has connected it to each one of those components. And I thought this was so powerful in terms of what we've been talking and in terms of you using it in your work. Um, you know, um, and it gives you a good understanding of how to use Joyner's theory for older adults. And you'll be getting the slide, so I would highly recommend you spend some time looking at it. Next slide. And the next few slides, I'm not going to spend a great deal of time on, but we have a vast cross section of people on the phone. For some, this may be very rudimentary. So I'm just going to cover this one slide. Warning signs for immediate risk. Someone is saying this out loud. My family would be better off without me. Remember that burdensomeness that Joyner spoke about? I just make things worse for everyone. Again, that is the burdensomeness. I can't take it anymore. I will never get better. I wish I could go to sleep and never get up. You don't need to worry about anymore. If you're hearing these kind of statements, it should raise a red flag for you. And next slide, I've given you a lot more examples of what you should be looking for. But I'm not going to go over them for a purpose of time. But if you could move to the next slide, Kelly. Here are some acute risk factors. That means immediately that you need to really take note of. The person has a current intent, plan, or is prepared. The method is currently very easily available to them, whether it's pills or a knife or a gun. They have access to lethal means, and here lethality often means firearms are present in the home. They have severe current hopelessness or pessimism, and that's very evident from how they talk and what they're communicating to you. They perceive themselves to be a burden. That is, remember what Joyner said. Recent diagnosis of chronic or life-threatening physical illnesses, which is what? Common in older adults, right? It could be cancer, life-threatening, or it could be a chronic illness which is progressing and getting worse. Severe loss of interest or pleasure, which we sometimes call anhedonia. Recent discharge from a psychiatric hospital, take note of that. Where do we send people when they're actively suicidal? We send them to an acute psychiatric hospital, right? Because we want them to be safe. But guess what? The highest risk for suicide is 30 days after discharge from an acute psychiatric hospital. And we're going to talk about that. So look out for that as a risk factor. They're isolated, alone, with very low social support. And they're experiencing some recent stressful life event. And we went over what are some of the stressful life events. Next slide. But very important, suicidal thoughts or actions are a sign of extreme distress, not a harmless bid for attention, and should never be ignored. I know sometimes in some settings we can get blasé. He says that every day. you know, I'm just tired of him saying this, but it's for attention. That's his way of creating a ruckus. No, it is a sign of extreme distress. So please, that should be our framework. Next slide. So I don't want to only talk about risk factors. There are protective factors which we alluded to. One of them is actually race and ethnicity, believe it or not, and one of them is gender. So what are some protective factors? Effective clinical care for mental, physical, and substance abuse. Wow. Is that news to you? And what did I show you about the gap in rural and urban? Why is it higher? Maybe we don't have access to effective clinical care in every area of Oregon. I heard someone talk about Oregon in terms of behavioral health as the haves and the have-nots, which is true, I think. Easy access to a variety of clinical interventions and support for help seeking. We need to be very flexible in what we are offering people in terms of support and prevention. It can't be rigid. I will only do this, that's what my clinic does, because you're going to lose people. Family and community support. I've already challenged you, Central Oregon, or from wherever you come. How are you promoting connectedness in your community? And then support from ongoing medical and mental health care relationships, as opposed to you have rotating providers and you never really build trust or a relationship. Next one, and this is, we all can do this. Skill in problem solving, conflict resolution, and non-violent ways of handling disputes. And remember that interpersonal therapy that I talked about, ITP, it's really about conflict resolution, and very important to teach these skills. And I'm going to venture that we should be teaching this from kindergarten. We shouldn't wait till we are 60 to learn these. It should be part of our curriculum. But for all of you who are therapists, case managers, peer specialists, start teaching these skills even now as part of your treatment package that you offer people. Cultural and religious beliefs that discourage suicide and support instincts for self-preservation. And that is one big reason why African Americans and Hispanics have very low rates of even burden of social determinants, because of their strong cultural and religious beliefs, because of their strong kinship, family, and community links that buffers against a lot of mental health issues.
Nirmala, excuse me
Next
for the
slide.
interruption.
And then,
Nirmala, I'm sorry. I know on my end that there was a long disruption in the audio there. Can you repeat that last piece about the social determinants of health?
Okay.
About that.
Kelly, if you can just go back. Yes, if you could go back one slide, Kelly. So what I said about cultural and religious beliefs are actually a protective factors. And remember, I showed you all the data on African American and Hispanics have very low rates of suicide, low rate because of health disparities and social determinants. But they have less prevalence of depression and suicide. And one of the reasons is because of their strong religious beliefs. The African American church, as you know, is well known throughout slavery and beyond to be a key focus of the community. So their religious beliefs, their kinship systems, their sense of connectedness to their communities and families, key as a buffer. So how do you promote that in your communities? And next slide is, what are some personal protective characteristics characteristics that help, as opposed to being rigid and inflexible. That you have a sense of meaning and purpose and hope. I always ask the question when I'm doing an assessment, what makes you get up each morning? What are the values that shape and drive your life? What gives you sense and meaning, which sometimes is a key factor when you're working with older adults who have lost their identity as productive members of society, because that's what our culture does. High self-esteem. How can you have high self-esteem when you feel, that as you get older, the media discounts you, or that if you're African American, that you are less valued? How can you build that sense of self-esteem? And then lastly, positive health practice, anything from meditation to prayer to being connected to something bigger than yourself, or to a faith community, or even to your social community. And then help seeking behavior. That is the number one reason why men overall have poor health, not just in terms of suicide and depression, but health in general, because of this lack of health seeking behavior and rigid adherence to social scripts, social roles, where men are almost kind of mandated to be quote unquote masculine, where you don't talk about your emotions, you don't reveal your emotions, you don't ask for emotional help, which, or even for physical help when you're having a heart attack sometimes. That what happens is, across the board, men have very bad health outcomes, high rates of cardiovascular death, so lack of help-seeking behavior. So all of you, especially the men on this phone, if you are in any way a professional or a paraprofessional that work with men, this should be something you should focus on for suicide prevention with men. Encouraging them to seek help, that it is okay. And that is one reason why we have such high rates of veteran suicide too, by the way, because it is, first of all, it's the military culture. And then, it is still heavily skewed in terms of gender. The veterans are still predominantly male. And recently, I just learned the other second group in Oregon, which is at very high risk for suicide, is construction workers, which is another male-dominated industry. So think about help-seeking behavior. Next slide. And here is a sad fact that I want to share. Most individuals who died by suicide, the older adults, received a health service the year before they died. This study showed that the majority of people who died by suicide, I'm talking about older adults, received a health care service in the year prior to death. And in fact, half of those had made a medical visit within 4 weeks of dying by suicide. 4 weeks, that means 1 month before that. The most common type of visit was primary care. And I know there were some people on this training today from primary care. Look at it, 4 weeks before they visited, and nobody asked them about their mental health. The individuals who made these visits were primarily older adults and specifically women. So this is a key opportunity to reach individuals at risk within primary care and medical subspecialty settings. And we have ample time. If they're coming 1 year or 4 weeks, we have ample time to improve. But if we are not asking, if we don't have a protocol in place, we will absolutely miss them and only focus on the issue they have come to us for. So what can you do? Next slide. Ask. Ask about suicide. Asking does not increase risk. So don't be afraid to ask. Are you having thoughts about killing yourself? You said that you're feeling that you can't handle it anymore. When you say that, do you mean you're thinking about suicide? And so with that, next slide, I'd like to introduce you to the safety suicide assessment 5-step evaluation and triage. So it involves, and you will get a handout, which I have sent to Kelly. Identify the risk, identify protective factors. Remember, we've talked about the risk factors, we've talked about protective factors. Conduct a suicidal inquiry, determine level of risk after you do that, and then document. And this comes out of SAMHSA. And so what is safety? So you look, next slide, you look at the risk factors. We talked about it, but in safety, you look at suicidal behavior, current and past psychiatric disorders. What did I tell you? Up to 97% of older adults will have a psychiatric illness, most often a depression. Look at key symptoms such as anhedonia, hopelessness, insomnia, command hallucinations. What are stressors? Very important. We talked a great deal about stressors. Change in treatment, especially were you discharged from a psychiatric hospital stay. That's a risk factor. Access to firearms and family history. So those would be the risk factors. Then you would look at what are the protective factors. Internal, what is their ability to cope with stress? Do they have strong religious beliefs or connection to, a faith community? What about their frustration tolerance? Those are all internal. And external. Do they have responsibility for children or a pet? Or they have a positive relationship with their doctor or a therapist? Or what is their social support? So this is all what you're assessing in your clinic when you're doing a suicidal assessment. And my hope is that you're documenting all of this. Next slide. Here is where you're actually inquiring about their particular suicidal ideation. You'd ask about thoughts, plans, behaviors, intent, ideation, how frequently, what's the intensity, whether it happened 48 hours ago, what is the plan, which very much includes lethality. Then behaviors, have they done this before? So that is all in the suicide inquiry. And then you decide on the risk and the intervention. And in safety, we have different levels which we are going to go over. And lastly, obviously, document. So next slide. So in safety, the risk levels are high. If you're saying it's high, that means they have a psychiatric diagnosis with severe symptoms. They have some kind of acute stressor. So protective factors are not relevant here. Potentially lethal suicide attempt, or they have persistent ideation, I want to die, I want to kill myself, with strong intent, and or suicidal, what we call suicide rehearsal. And admission generally indicated unless a significant change reduces risk, and you put suicide precautions into place. So moderate, multiple risk factors, few protective factors. There's presence of suicidal ideation with plan, but no intent or behavior. Admission may be necessary depending on what the risk factors are. Then you'll develop a crisis plan, and then you'll give emergency numbers. And low is, there are risk factors, but very strong protective factors. They have a strong belief, religious belief. They're connected to their church, and they're daily contact with their minister, or they have a very good circle of friends who is contacting them daily to provide support. So you're checking on what are their strong protective factors. So they have thoughts of death, but no plan. You would make an outpatient referral for symptom reduction, and you would always give them those emergency numbers. Okay. And you will be getting this information in a very nice handout. So you will be able to use it in your work. So the next slide. So what can you say if you're in a primary care setting and someone tells you, yes, I'm suicidal, as as a clinician or case manager or a nurse RN, you can say, thank you for being honest. I know this can be very difficult to talk about. I'm glad you told me. I might be able to help. It sounds like you're in a lot of pain. I'm so sorry you're going through this. So saying something empathic and connecting with that person is key. Next slide. You can then ask some open-ended questions. How long have you been feeling this way? Will you tell me the story of how you got to this point? How did you get to this point where you're feeling such deep pain? Can you tell me the day you were feeling most suicidal? What was happening then? And how did you cope? So these are all some questions that you can follow up with. Though we are going to go into in depth with this in a few slides. Next slide. So what you have to do is recognize the tension. The goal of the person at risk is to end their life by suicide. And your goal as a helper is to keep the person alive and calm your own fears. How many of you have actually been with someone who is suicidal? Or you're a therapist in a crisis program where you're doing these assessments? I don't think when I did these assessments, there was ever a day where I was relaxed or blasé about it. Every time I got a person in my office where I was doing, it really raised my level of risk. Am I doing the right thing? Is my assessment right? Am I really helping this person? How do we keep this person alive? So it's very real that you yourself have to calm your own fears. Next slide. This is a mnemonic that we teach to people in busy primary care hospital settings who may not be mental health specialists. It's called Is Path Warm, and stands for, Is Path Warm is the acronym. You check for ideation, substance use, purposelessness, that was the meaning and purpose, anxiety and agitation, feeling trapped, hopelessness and helplessness, withdrawal, anger, recklessness, and mood changes. And again, this is a mnemonic. It comes out of the American Association of Suicidology, but it's a easy way to carry this kind of framework in your head, and that's why I have it here. Next slide. I'm going to skip this next slide. You will be getting it so you can look at it. Again, this is for busy non-mental health clinician. Could you just go back one slide? So I will let you look at that. But let's move on to the P4 suicidality screener. What do you do after you do the PHQ-9? And the score comes high, and there is a question of suicidal thought or suicidal risk. This is a screener that you can follow up with. It's called the P4 suicidality screener, and we recommend it for older adults. Have you thoughts of actually hurting yourself? And you can see there's a decision tree. No. And if it's yes, then you go on. Have you ever attempted to harm yourself in the past? If it's yes, have you thought about how you might actually hurt yourself? There's a big difference between having a thought and acting on a thought. How likely do you think it is that you will act on these thoughts about hurting yourself or ending your life in some way? And there are three options. Is there anything that would prevent you from harming yourself? No. If they say yes, remember those are the protective factors, you actually write those in. No. This is what the P4 screener is, and and we have given you the scoring there, how you score it, and can you see the shaded areas? If you have even one of those items, you're at high risk. And so this is what our recommendation, next slide, is for interventions for the P4 screener. If you're at low risk, you have passive thoughts of death or ideation, active suicidal thoughts without plan, no previous high lethality attempt, absence of psychosis, minimal risk factors, you're considered low risk. Okay, next slide. And this would be the interventions. You express concern, you help identify coping strategies, very important. You activate their support system, you call their caregiver, you call their spouse, you call their adult child, whatever it is, their nurse RN at the nursing home. You have a planned follow-up, you call and give support, and you make referrals. So that is for low risk. Okay, next slide. Moderate risk using the P4 screener, you have active thoughts with a plan, active thoughts with a previous plan, you have psychosis or comorbid substance use present, which is rare among older adults, but this is, you can use it across the age group. Lethal means determined but not readily available. They may say guns or they may say medications, but it's not readily available to them. Next slide. This would be the interventions then. Lethal means reduction. You have a plan to reduce the lethal means. You call and you have the guns that you lock them up or remove them from the home, or you take the pills and give it to a family member to distribute at bedtime and see that they are swallowing it, whatever. So that is lethal means reduction. Regular clinician-initiated phone check-ins that you're calling by phone, every other day to check how they're doing, and then you repeat the assessment. Next slide. Now, high risk is you endorse the probability of complete dying by suicide. You lack any preventative factors, which are those protective factors, and lethal means are very readily available to you. You have guns, you have medications, you have your car, so you can use it as a weapon. So all of that is available to you. Next slide. The response would be to ask additional questions. You don't leave the person alone, and you try to facilitate a hospitalization for someone who is at high risk using the P4 screener. Next slide. And so what I really, and if you can move to the further one more slide, Kelly. What I would really like to focus on now is in Oregon, we are promoting the use of the Columbia Suicide Severity Rating Scale, CSSRS. This is a questionnaire used for suicide assessment developed at Columbia University with NIMH support. So, so it was supported by NIMH. And the risk version is fairly long, and its use is to establish a person's immediate risk of suicide. And I'm going to ask you a question at the end about training, so let's hold off on that. And I will be also sending an additional document to Kelly for distribution, which is where the latest version is, where we have combined the safety. Remember, I just went over the safety with the Columbia, and I will be sending it out to all of you. And it's pretty self-explanatory, but at the end of the session, I will be talking about training opportunities. So, but remember, we are advocating the use of the Columbia Suicide Severity Rating Scale. Next slide. How many of you remember writing suicide contracts? Angela said, I have worked 35 years in behavioral health, and I've covered every aspect of behavioral, including crisis. I was a civil commitment. I also worked as a mental health designee, where I could put people under a civil commitment. I've done crisis work, crisis phone line, where that's what we wrote. We wrote suicide contracts. If you all remember, I promise to not hurt myself or kill myself, and I will call you if I have suicidal thoughts. That was essentially, I may be, really abbreviating it, but that was kind of the crux of what a suicide contract was. But guess what? Now we are saying no suicide contracts. Do not make a suicide contract. Next slide. Instead, saying safe plan. And where is that coming from? A no suicide contract takes the form of asking the client to promise not to kill themselves and to contact a professional during times of crisis. It was literally that. We could have embellished it here and there with a little different, but that was the crux. Guess what? There is no empirical evidence that supports the effectiveness of no suicide contacts for preventing suicidal behavior. No data that it supports prevention of suicide. Instead, next slide, I'd like to introduce you to safety planning. A safety plan is a brief intervention that can significantly reduce suicide attempts. Rather than telling the person what not to do, that is what we were saying in a contract, don't kill yourself. A safety plan helps the person know what they can do to feel better and stay safe. So can you see the difference? It builds on self-efficacy and empowers the person. And this safety plan is also sometimes referred to as Stanley Brown's safety plan. And why is it called that? Because it was created by two psychologists in 2008 by the name of Barbara Stanley and Gregory Brown. So if you hear Stanley Brown, we are referring to safety planning. So can you see the difference? It tells the person what they should do to feel better and stay safe. And it builds on their sense of self-efficacy, their capacity that I can do it, and empowers them. I can do it. I can stay alive if I follow the plan that I've put into place, and it empowers them as opposed to feeling hopeless and helpless. That's what a safety plan or a Stanley Brown does. Okay. So where is this coming out of, this Stanley Brown? Next slide. I told you it was created by these two psychologists in 2008. It is a brief intervention. So remember, the contracts was something therapists and patient wrote at the end of an assessment and gave it. This is a session in itself. So it takes 20 to 45 minutes. It provides the client with a prioritized and specific set of coping strategies and sources of support that can be used in a suicidal emergency. The intent is to lower risk by consulting a predetermined set of potential coping strategies and a list of individuals and agencies they can contact. The key word is predetermined set. How many of you can think clearly in a crisis? How many of you can think clearly in a panic attack? No, you can't. So here the safety plan is predetermined. You'd work on it before you reach that suicidal crisis. So you can pull out your plan and look at, oh, I said I can do this to feel better. And that is what Stanley and Brown created. And it's actually a template which I will be sharing with you. So next slide, what are the components? Recognizing warning signs, your personal warning signs, employing internal coping strategies, utilizing social contacts as a means of distraction from suicidal thoughts, contacting family and friends who may help resolve the suicidal crisis, contacting mental health professionals, and reducing lethal means. So you can see it's a hierarchy, correct? Definitely. Contacting health professionals is way at the bottom, not the first thing you do as we used to write in our contracts. Next slide. Again, I'm just fleshing those elements out for you. 3 warning signs that a crisis is developing. And those could be thoughts, images, moods, situation, or behavior. So obviously this is a collaborative endeavor. You're sitting with the client. You may know the client well, you may not know the client well. So you're exploring what are those thoughts or images which tell you that, it's imminent, that it's a warning sign. And you put them down, 3. 3 internal coping strategies, and those are things I can do to take my mind off my problem without contacting another person. It could be relaxation exercise, meditation, running, physical activity, listening to music, whatever. Next, people and social settings that provide distraction. Next, people whom I can ask for help, family or friends. Next, professionals or agency I can contact during a crisis. And then making the environment safe, guns, medications, knives, all of that. And then lastly, this is not part of the actual plan, but it is like an addendum. The one thing that is most important to me and worth living, and for older adults, let me tell you, very often it's their furry companion, their pet. It could be their dog, it could be their cat, it could be their parrot. That is important and worth living for. So explore every option. Next slide. So again, this is, I'm putting it in a different way, the safety plan components. Setting the stage, you set the stage, you make the environment safe, and then what are the warning signs? On my own coping, with a friend coping, tell someone coping, and then lastly, clinical contact. So can you see on my own coping, what can I do myself? With a friend, that would distract me, and then telling someone else, like calling help to a family member or a friend. That's on your list, by the way, this is all written. And then lastly, contacting your therapist or your community mental health program. Next slide. And okay, you don't have that. Do you have the actual template for the safety plan, Kelly? No? There was another slide I had in after this. Can you see? If you don't, then it's okay.
Okay, I'll check the next slide.
Okay. It says safety planning template. That's okay. It will come. People will get it. That's fine. So you will be getting this. There were 2 more slides, but maybe I send you a version which did not have it. So why means matter. Suicidal crises are often brief. The deadliness of an attempt depends in part on the method used, right? Taking pills versus gun. We know what is more deadly. And 90% of those who attempt and survive don't go on to kill themselves. That is startling. 90% never have another suicide attempt or never die by suicide again. If they survive the attempt. Next slide. And again, this is the work of next slide of Thomas Joyner. The risk of suicide is amplified. No, if you could go back. The risk of suicide is amplified when clients report a specific plan that readily available lethal method, that involves a readily available lethal method. Okay, so it's amplified. Key components of the safety plan, which we talked about, the Stanley Brown, involves eliminating or limiting access to lethal means. So safely storing medications, implementing firearm safety, and restricting access to knives. So part of the plan is keeping the environment safe. So you're actively negotiating for lethal means restriction as you're working with your client to develop the safety plan. Next slide. So now that I've gone over the 2 major kind of screening tools, which I will tell you more about, the Columbia, we talked about the safety, and we talked about the Stanley Brown safety plan. Here are some other treatments and therapies. There are lots of brief interventions. We talked about, Stanley Brown, follow-up supportive phone calls and postcards. And you may be wondering, what is Nirmala saying? Well, I'll come to that in a minute. Cognitive behavioral therapy, dialectical behavior therapy, clozapine, which is an antipsychotic, to date is the only medication with a specific FDA indication for reducing risk of suicide, especially for patients with schizophrenia and schizoaffective disorder. And also this is off-label, but very often lithium is also used to reduce suicide ideation. And I should also mention currently esketamine is showing a lot of promise for depression treatment and for chronic suicidal behavior. So let's next. So let's unpack all of the therapies. I'm not going to spend a great deal of time, but did you know there is a cognitive behavioral therapy especially designed for suicide prevention? It's called CBT-SP. And the principles are it's time limited. You'd still have to develop an individualized case conceptualization. But what you work on is promoting adaptive thinking patterns, teaching them problem solving, helping them manage stress and emotional arousal. So the target is reducing suicide risk. All of you are interested in this, let me know. You can write to me by email. I can see how I can get you more information on CBT-SP. Next slide. And here I'm just giving you a little bit more information on CBT-SP. Which is common to cognitive behavioral therapy, where you do what we call cognitive restructuring. You identify and evaluate cognitive or automatic thoughts. You teach emotion regulation strategies by using, various skills here. And then other CBT strategies are behavioral activation, which is very much used for older adults, and problem-solving therapy. Next slide. Many of you know of DBT, and that it is offered as an evidence-based practice for everyone on OHP. Numerous studies have shown DBT to be effective in reducing suicidal behavior. It has 4 components if you're following it to fidelity: a skills training group, which is for 24 weeks, individual treatment, which runs concurrent, once a week, then phone coaching upon request by the client. So you also have phone coaching available. And then the therapists meet in a consultation team. That is, so if you follow DBT to fidelity, that is what it entails. And as you know, it was developed by Dr. Marsha Linehan out of the University of Washington, right in our backyard here. I don't know how many of us just use the DBT skills manuals, which is not following it to fidelity, but still very useful. But if you're making a full referral for the DBT program, it involves all of this. Next slide. And, I talked about postcards. Did you know that? Sending a caring text or a postcard to say you are thinking about the person, someone who you've seen and who's suicidal, could be a life-saving intervention on its own. And by the way, this was in a random controlled trial, and I've got my citation there. It reduced suicide attempts. Help patients, call patients to offer support and encourage engagement. Do you know 70% of people never get to their first appointment? Someone who's suicidal from the ER, they fall through the cracks or never show up. So can you imagine doing an outreach call till they connect? And then also offering briefer cognitive behavior therapy models in the hospital. But my take-home message is postcards and caring text messages. All of us can do it. Yes, check with your programs, community mental health programs, and using text and whether it's encrypted or what. But it is proven to save lives. Postcards. Next slide. So we are calling it caring contact. Post-discharge follow-up contact with high-risk individuals is very effective strategy. Caring contacts are not treatments, but can be used as adjuncts to treatment to keep the individual engaged so that they will follow up with what are evidence-based treatments. So any of you who work with highly vulnerable people, this is a simple thing, caring contacts, and it is proven to be effective. Next slide. In Oregon, we are also promoting this collaborative Collaborative Assessment and Management of Suicidality, called CAMS, developed by Dr. David Jobs. Much of this is for youth, but it's also available and applicable to older adults and to adults. Here, outpatient care is the explicit goal of CAMS, which is designed to strengthen therapeutic alliance and increase motivation. So this is not a treatment modality, but it's really a therapeutic framework that emphasizes a collaborative treatment planning process between the person and the clinician. So if any of you are interested in knowing more about it, please Google this and learn about Dr. David Jobs. And however, we are also promoting it in Oregon, especially for youth. Next slide. How many of you have heard of ERPOs, or extreme risk protection orders, or sometimes colloquially called red flag laws? This became legal, or became the law in Oregon in 2018, where law enforcement, immediate family or cohabitants can petition for an extreme risk protection order. In fact, I was consulting about 4 weeks ago with a major older adult program in the Portland metro area, where I suggested an ERPO. And the providers had never heard of this red flag law. And they were very grateful to me for mentioning this to them. I subsequently sent them the forms and all of that and told them to work with law enforcement to remove the gun from this very compromised older gentleman. So in 2018, Oregon, we had 166 ERPO petitions, 2/3 for individuals who were suicidal. Yes, and it protected them. So I want you to be aware of this law. I don't know how many of you have used it, how many of you were aware of it. If you want to know more about it, please email or put it in the chat box for us to look at later. For next slide. For many of you some of you work in primary care settings, or this is remember I said older adults come 4 weeks before. Half of them who died by suicide saw their medical provider, like a PCP, in a primary care setting, or they went to a specialty setting, such as maybe an endocrinology clinic or a arthritis or orthopedic clinic, where they were seen, but nobody asked them about depression. My suggestion would be optimize diagnosis and treatment of late life depression by using some of these evidence-based practices, which I've listed here, which I'm not going to go into, but you have them here. But more importantly, optimize treatment of pain, sleep disorders, and other physical symptoms that decrease quality of life and increase suicidal ideation. Include friends, relatives, and caregivers in the treatment conversation. So any of you who work in primary care settings, that is where older adults come. Do you screen for depression? And what do you do after you screen? Also treat pain and sleep disorders because they compromise quality of life. Next slide. Medications we've already talked about, clozapine, I told you, and then we talked. I talked about strong evidence for lithium. Is also associated with decreasing. And then, as of March 15th of last year, the FDA approved intranasal formulation of esketamine for treatment-resistant depression. And right now, lots of promising studies are being done on chronic suicidal behavior, or esketamine being extremely effective. And unlike antidepressant medications, which take 3 to 4 months to take into effect, esketamine is almost immediate. So think about your formularies, think about your patients. Is that an option in Central Oregon? Next slide. Why should you address suicide prevention in emergency room department? You remember saying, Nirmala, are you crazy? Why emergency room? The risk of suicide attempts or death is highest within 30 days of discharge from an ED or an inpatient psychiatric unit. Did everyone hear that? The highest. If you are discharged from an ED where you've spent maybe 2 nights, or in an inpatient psychiatric unit, you're at highest risk. Up to 70% of patients who leave the ED after a suicide attempt never attend their first appointment. Remember, I said they are lost to follow up. What could make a difference is a caring contact, a text message, a phone call, till they get connected. Approximately 37% of individuals without a mental health or substance use diagnosis who died by suicide make an ED visit within a year of their death. For whatever reasons, they were in the emergency room. But my take-home message is post-discharge for suicidal ideation or suicidal attempts from an ED or a psychiatric inpatient unit, you are at highest risk for 30 days. Next slide. This was a study. We looked at emergency department study reveals patterns of patients at increased risk for suicide, and this was done in California. So individuals who presented at the ED with deliberate self-harm had a suicide rate in the year after the visit of 56.8 times higher than those of demographically similar Californians. So more than half of those who presented with self-harm to the ED, 1 year later died from actually dying. They died by suicide. Those who presented with suicidal ideation, the suicide rate was 31 times higher than among Californians overall. Men and those over age 65 had higher suicide rates than women and people, younger people who came to the ED in California. Comorbid diagnosis, patients who presented with self-harm and those with bipolar disorder, anxiety, or psychotic disorders were more likely to die by suicide than those without those diagnoses. So all of you who work with people with serious mental illness, if they are presenting in the ED with suicidal ideation or suicide attempts and have bipolar disorder, anxiety, or depression and psychosis, they're at very high risk of dying within the next year. Next slide. The same study went on to say patients with suicidal ideation, comorbid diagnosis of depression was found to be associated with increased risk, which we've already talked about. But this is across the lifespan. Patients with depression or alcohol use disorder had increased risk from this study. And very interesting, the last point, risk of death via unintentional injury, that is accidents, was also elevated in this group. 16 times for the self-harm group and 13 times for the group which just had the ideation. Most deaths were by overdose, underscoring the overlap between suicide and overdose risk. So this is a very sobering study. So all of you who maybe work for a CCO or are some way connected to population health, this should be kind of like a wake-up call. What happens to people who come to your emergency room department with self-harm, suicidal self-harm, or with suicidal ideation? Next slide. So how can emergency rooms help? Brief patient education. Help them understand their condition and what are their treatment options. Safety planning, the one that we talked about, the Stanley Brown. Lethal means counseling. Rapid referral. And then caring contacts. following up with postcard letters, email, text messages, because we need to take this problem seriously. Next slide. And prevention is key. There are many different levels of prevention. One is universal prevention. Focus on the entire population. Like I told you, 65 plus, very high risk for suicide. So you do things like depression screening, you do some education and community education, you talk about suicide risks, and you talk about how to limit access. That is called universal prevention. So you do it for the entire group which is at risk. Selective prevention is where you target individuals who are at increased risk, but don't display any kind of suicidal thoughts or behaviors, but have other risk factors. So you focus on, say, reducing disability, enhancing independence, providing therapies for negotiating loss or bereavement, or losing your driver's license, addressing social isolation. So here you're really looking at a selective group of people who are at increased risk. Next slide. And the last group is indicated prevention. These efforts are aimed to actually prevent suicide among people who are at high risk, where you have already assessed them for that. Routine screening for depression and management of late life suicide for this group, which you have already identified is suicidal and will continue to be at high risk. Okay, next slide. And here are some ways that all of Central Oregon should be looking at. Actually, could you go back? Could you? Okay, I don't know which slide you have, but I am on something which says enhance suicide prevention. Next slide. Yes. This is something you all can do in Central Oregon. Prioritization of suicide across all levels of care, not just community mental health, across. Effective identification and assessment. Comprehensive surveillance systems where you're assessing the entire population. I'm not going to go into all of them, but here are some strategies which you should be looking at as a community or as a healthcare system. Next slide. And I am going to skip these next few slides. It's for you to take a look at. But I'd like to go to the slide which says preventing suicide. Kelly, if you can move one more slide forward. And this comes out of CDC. Look at what they are suggesting as a community. Strengthen economic supports, financial security, strengthen access and delivery of suicide care, create protective environments that reduce access to lethal means and to alcohol, promote connectedness and community engagement, which we were talking about, social connection, teach coping skills and problem solving skills, and social emotional learning programs right from school to older adults. Identify and support people at risk by doing gatekeeper programs, crisis intervention training, treatment of people at risk, and treatment of people who have attempted. So this is coming right out of CDC. And I would urge all of you on the phone to print this and take it back to your agencies and organization and see what are you doing and what are you not doing in terms of the work, and where can you strengthen your response to suicide. Next slide. Just a word about postvention, and we are really promoting it in a big way in Oregon. Every person who dies by suicide leaves behind survivors who are profoundly affected. These survivors experience a range of emotions from guilt, shame, grief, embarrassment, anger. And one of my best friends who has since passed on from cancer, her son died by suicide at age 16, and it had lifelong impacts on her. And I shared with her in her grief and her guilt. And so postvention refers to programs or interventions for survivors following death by suicide. And this was a term coined by Dr. Edwin Schneidman. Next slide. Legal concerns. We don't have a lot of time, but I just wanted to talk about some legal concerns, because some of you are therapists, etc. That you should always report it with your institutional guidelines. Next slide. Always review the case, and then but really more importantly, the next slide. I want to focus on that. Prediction, risk, and document. Risk is something that can be assessed and documented. The absence of a risk in the chart is a liability. And the presence of a risk assessment in the EHR is an asset. So how important is documentation? And next slide. And I just want to briefly show you what are the 4 Ds of medical malpractice as it applies to suicide, but this applies to other also. Duty, damages, dereliction of duty, which is a negligence, and direct causality. That means you have deviated and caused it. So this is what, that is why risk mitigation is so important in terms of documentation. Next slide. This is a nice thing to keep handy to give out, which is the 5-step for someone help someone in emotional pain. I would highly recommend people, especially in long-term care settings, in non-traditional mental health settings, to have this handy, to put it out somewhere that people can see, especially staff, so they know what to do. Similarly, about the next slide. And they have the resources at the bottom, so you can actually go to the direct link and print it. Next slide. Here are some, looks like maybe, Kelly, we are using an older version, but that's okay. Because do you have something which says OHA resources? Can you go to the next slide? Okay, you don't have that, but that's okay. Here are all my resources which you're welcome to go to look at. You can download a lot of them for free. Not a lot of them, all of them for free. What I wanted to talk about was some of our OHA resources. And Kelly, if you can put up the poll question. We have a poll question coming up. Who would like training on the Columbia, which is the screening instrument, and on Stanley Brown safety planning? You can say yes and no. And if you say yes, if you can please add your name and the organization you are representing, because sometimes it's a chat, it's a Gmail address and we don't know where you work. And I will let you know after we see the poll. We have a good number of people on the phone, 94. Let's give it a few more minutes, seconds. And why don't we go and see what we have, Kelly? So 58% of the audience would like a training, and I can see lots of people putting their names and the organization they work for. I will ask Angela and Kelly to collate that information for me, and then Angela and myself will be getting back to you with an opportunity for training. In addition to Stanley Brown and Columbia, OHA, Oregon Health Authority that I work for, also provides training in QPR, which is question, persuade, and refer, which we are really promoting. We also provide training in assist, in mental health first aid, and for younger adult people who work with younger adults, we also give training in safe talk and sources of strength. But the training that I'm going to offer is in the Columbia and safety planning. So thank you, all of you. That was a nice number of people who stayed on with us till the very end. I appreciate your being here today. My hope is that we've all been challenged to work with people who are in distress in our communities to reduce the rate of suicide in Oregon and in your communities. And I am happy to take a few questions and comments. Kelly and Angela, we can move to the camera format. You can,
Okay.
and here, so we can move to that.
Okay, thanks,
And
Nirmala, for that. We have several questions. And if we don't have a hard stop at noon, Nirmala.
I don't mind going on for another 5 or 7 minutes beyond 12 if people want to stay.
Okay, so Elaine Ambers from Pacific Source asks, how significant is the connection between chronic pain in older adults and suicide? And are there statistics on this?
So I can work on getting you the statistics. I don't have it handy, but it is significant. And pain associated with chronic disabling illness that comes with older adults, whether it is cancer and or osteoarthritis or any other kind of pain which is disabling. If you remember the 5 Ds framework, that is one of the Ds.
Okay, and here's a meaty one. From Anonymous, we have many of my older adult clients, 60 to 79, are not able to obtain proper and adequate pain management due to their PCP's fears of overprescribing and possibly being sanctioned by authorities. How do we advocate for these clients without overstepping our role as behavioral health providers?
Okay, so we never say that you should not treat pain adequately, especially in older adults. However, opioids should be used with caution in older adults. We recently held a conference 2 weeks ago where we looked at what are all the other therapies available. Whoever sent this question, if you don't mind writing to me by email, I can discuss this further with you.
Okay. And for those of you that are wondering about the EADS code, it's 51HOKE. Reach out if you missed that. Last question, and this is to the group. Ann H. writes, COVID prevents a lot of community activities. Does anyone have ideas on how to promote this aspect of suicide prevention, especially for older adults who don't have computer connections, senior centers and libraries are closed, etc.?
One way I would suggest, and this sounds really simple, would be also, you can use telephone, so it's not just video. So really engaging in a social contact via telephone can be as effective. Yes, video is a lot more effective, but connectivity, broadband, digital literacy, those are all issues. So even using old-fashioned telephone has been shown to be effective. Okay. Yes, nothing replaces personal physical contact, but someone even calling with a caring call goes a long way by phone.
And we should also point out that CARES Act funding went out statewide. Many of your county mental health providers are in charge of disbursement. Ask them what they're doing. What programs are they encouraging or trying to set up to address COVID and the older adults?
Absolutely. Yes. Ask your community mental health program, how are you using the CARES Act funding to outreach older adults?
Definitely.
They are one of the populations targeted in the funding.
Okay, so we have quite a few folks that wrote in to say that they're interested in some follow-up trainings. And I believe L. Harrison had a question about the name of the assessment. I believe it's the PS4. PS4.
P4.
P4.
The P4 screener.
Okay.
You can Google it, P4 screener, and if you get my slides, you'll see the citation at the bottom.
And then the most common depression assessment that the state is recommending now. Can you remind us of that again?
PHQ-9 is the depression assessment everyone is using. If you want to be very specific for older adults, the Older Adult Initiative, which Angela and I are part of, we are recommending the GDS-15. The suicide screening is called Columbia. So it's not a depression screening, it's a suicide screening. But for depression, PHQ-9 is being used widely in Oregon.
And then our last question comes from Anonymous, who's writing in some really good questions. What are the legal implications of doing a video consult in someone who is experiencing suicidal ideations? And I believe that we have some leeway during the time of COVID these days.
Okay, they have really relaxed telehealth platforms and codes. So it's absolutely legal to do a suicide risk assessment via video. Of course, if you're going to say they're at high risk, then you have to put a plan in place right away. And yes, mobile crisis programs are going out in person to do some of those assessments. But because of COVID-19, a lot of the telehealth platforms have been relaxed, and also codes have been relaxed.
Thank you. That's a good reminder. We're giving a lot of leeway.
Yes.
I'm sorry, did you say billing codes? You cut out.
Billing codes, and also the platforms you can use.
Okay, right. Well, folks, that has brought us to the end of this presentation with